We are good to go. So thank you everyone for joining us today. My name is Vito Garrity. I'm the Senior Program Manager here at the National Hispanic Medical Association. We are here for the 19th session of our virtual briefing series, where we are focused on addressing vaccination uptake for COVID-19 and flu in adult Latino communities. So thank you all for joining us today. I will be your moderator. Dr. Rios was unable to make it today, but we do have a fantastic panel lined up for you. We have Dr. Juanita Mora, Dr. David Garza, and Dr. Hector Cabrera. We will be speaking about the tridemic that we saw this winter and that we're currently seeing. So without further ado, I will jump into the housekeeping. So your microphones will be muted, but we do really welcome a lively Q&A session at the end. So please feel free to type your question into the Q&A box. I will be addressing those at the end. We'll have about 20 minutes of some live, robust Q&A. So please don't be shy. Put some questions into the Q&A, and we will address them at the end with our panelists. Also, we are very conscious about making these webinars as engaging and as educational as possible. So we do a post-webinar survey at the end of every webinar. Please fill that out. We do incentivize it, of course, because we want to hear from you. So there is an opportunity to win a raffle Amazon gift card. And this will be recorded, and we will house it on the NHMAMD.org website. And we will also be live on Facebook. We'll send out the recording and the slides about a week after the event to everyone who registered today. So just a quick update in terms of the NHMA Vaccinate for All campaign. Thank you to the CDC. Also would like to shout out Health Monitor Network for co-branding this event with us. But we are funded by the CDC. And I wanted to share these two dashboards that was recently shared with us for the respiratory virus and also emergency department visit data. Some very useful dashboards. We'll post those on our website after the event for everyone to take a look. I think you'll find some intriguing data in there. Some other updates: the FDA is expected to decide by spring whether to approve Pfizer's vaccine to prevent respiratory syncytial virus, or RSV, in adults 60 and older. They're also proposing a once-a-year regimen for coronavirus immunizations. The big thing here is that vaccination in the Latino community is still a problem. 2 years after FDA's COVID vaccine approval, Latino people have been less likely than their white counterparts to receive a vaccine, according to the Kaiser Family Foundation. Also, the big topic is Medicaid terminations. The majority of those who will lose coverage will be people of color. So that will definitely be on our radar as we continue the third year of our Vaccinate for All campaign. So to start it off, I will ask Dr. David Garza, Associate Dean of Clinical Affairs at the University of Incarnate Word School of Osteopathic Medicine, to join us and talk a little bit about flu. And Dr. Garza is also on the AOA Board of Trustees. Dr. Garza, please go ahead.
Thank you, Vito. And I'm honored to be among this panel of speakers today. It's always a pleasure to talk about the medical conditions that affect, as I say, my people, our people, because there are a lot of them that tend to pick on us indiscriminately and disproportionately. But sometimes we do it to ourselves. I'm going to start with a personal story. When I was an intern back in 1990, my wife became pregnant with identical twins, and I was just trying to do my best to get through the year. One of the twins had a birth defect in his lung and had to be delivered early. They both got delivered early. The surgery went well, but he got an infectious disease that he did not survive. And so At 2 weeks of age, still in his incubator, we said goodbye to him. And we're not able to hold him and embrace him and hug him until moments before his death. It was not flu related. It was not an infectious disease that you catch from somebody else. It was a complication from the surgery. The point was that we lost a child that we didn't even know. Which brings me to the flu. This year in the United States, the first 2 pediatric deaths were in Texas. There was a 3-year-old girl in Hidalgo County, which is in the Rio Grande Valley, who had not been vaccinated, although she had been vaccinated in previous years. She was one of the first 2 pediatric deaths in this country. The second one was a 4-year-old girl whose vaccination status was not known from the Temple area, which is Central Texas. So those are the first 2 documented pediatric flu-related deaths in this country. It happens every year. And while pediatric cases are this year less than 1% of all the adult deaths, they are devastating. So what is the flu? If you don't already know, it typically consists of cough, sore throat, body aches, and fever. It's like a very bad cold, Most deaths are going to be from pneumonia. This flu season, which started in the fall, there have been 91 pediatric deaths. So those 2 that started in Texas spread, and as of last week, there have been 91 pediatric deaths. Overall, there are an estimated 25 million people who have become ill in this country from the flu, including 280,000 hospitalizations, and as of last week, about 17,000 deaths. So why are we talking about Latinos and Hispanics? Several reasons. There are medical conditions that are likely to make the complications of the flu worse and perhaps more lethal. Diabetes, hypertension, obesity, things that are very, very prominent in the Hispanic community. Hispanics are also likely to not have as much insurance. About 20% of Hispanics under the age of 65 don't have insurance. They are more likely to not have a personal physician, and about 27% of adult Latinos do not have a physician. They're more likely to be economically challenged, and 40% of Latino adults do not get vaccinated. Beyond that, there are also language barriers and other things that result in reluctance to get vaccinated. So we are a population at higher risk for genetic reasons, for lifestyle reasons, and demographic reasons. So what's the best way to prevent the flu or flu complications? An annual flu shot. Stay healthy. Stay away from crowded areas. Stay home if you're ill. Use a face mask. Wash your hands. Things that we have learned from past seasons of the flu and lessons that were cemented by the pandemic. So if there's one good thing that came out of the pandemic, besides how to crank out a vaccine very quickly, is how to stay healthy. In fact, the last 2 years, we saw a downturn in the number of people with the flu, probably because people were staying away from crowds, they were wearing masks, they're using the hand sanitizers, etc. So how does one get the flu shot? Very often it's covered by your insurance, but if you don't have insurance, very often it's covered by your health department for free at a pop-up clinic. Sometimes employers will provide the flu shot. There are a variety of ways to get the flu shot, and they're available. I know that in San Antonio, for example, Metropolitan Health has pop-up clinics all over town, and you can walk in and get a flu shot for free. And even if you're healthy and you think you're healthier than other people, it helps to get a flu shot because it helps to keep you from getting sick and passing it on to somebody else who is at higher risk. That's when you become a vector. So my comments are going to conclude here fairly soon. with another appeal. You wouldn't ride in a car without a seatbelt. And if you drive your children without buckling them in properly, that's something, again, you would not do. When a parent hugs their child, neither of them think it's going to be the last time. There are things that we all can do to keep that embrace from being the last one. An annual flu shot is the most effective way to prevent influenza from breaking families apart. And as you will hear from my esteemed colleagues on this panel, the presence of COVID and the ever-present RSV virus make that flu vaccine even much more important, because they all team up, they gang up, and they can make people profoundly ill. Thank you for your attention, and those are my comments.
Thank you so much, Dr. Garza. Really appreciate that. I will reshare my screen and we'll kick it over to Dr. Mora. All right, Dr. Mora, it's all yours.
Thank you so much. And thank you for sharing that heartfelt story, Dr. Garza. And I honestly think we've all heard very impactful stories like yours, and we want our Latino community to do well. So it's my pleasure and honor to be here with everyone today. And I'm going to be speaking on RSV and its impact in the Latino community. So as we know, RSV is a common respiratory virus that can affect people of all ages. So I think most of the time people think, well, it's just a pediatric disease, just as like the start of this season. But we found out that a lot of adult doctors, a lot of geriatricians had to learn a lot about RSV this season, because guess what? We had a lot of older adults who became infected with RSV, as well as kids. In our Latino communities, you'll hear me speak, one of the things that we know is there's a lot of multi-generational homes. So we have all these little grandkids who brought their grandparents a present from school or daycare, and that's called RSV. And so in my practice, I got to see tons of families in Chicago fully infected with RSV. I would see the kids, the brothers and sisters, the parents, the abuelitos as well too. So it really became one of the hardest hit viruses to hit our Latino community. When we talk about RSV, it is so common that nearly 100% of children will have been infected with RSV by age 2. And it's the leading cause of hospitalization in infants. When we talk about it, it's so contagious, it's spread from person to person through coughing, sneezing. Kids put everything in their mouth. If you think about it, especially in common areas in daycare and schools, they share cups, they share everything. So this is why we saw RSV truly hit. And we were coming out of a pandemic this season, and we had a lot of kids going back to school, to sports, and not wearing a mask. So we saw RSV really hit through the roof, and we had the worst season that we've had since 2012 this season. So when we talk about underlying risk factors in infants that we all need to know, so what puts an infant at risk for RSV? So most kids will do well, just common cold symptoms, but what factors should we look for when we're like, well, this is a high risk infant for RSV? 1, born prematurely. 2, very, very young. 3, they have chronic lung disease or chronic heart disease that puts the babies at risk for RSV complications. Any weakened immune system or any neuromuscular defect, because remember, then they can't pass the phlegm or anything else. So all that gets stagnant in the lungs, and they are at very, very high risk for RSV infection and complications, which is why if you have a baby with any of these conditions or a patient with a baby with any of these conditions, they have to be extra careful during RSV season. So besides infants, who else is at risk for RSV? So I also talk about all the grandparents, right? So we found out this season that older adults greater than 65 years of age were the highest risk. Just like Dr. Garza mentioned, So people who are immunocompromised are going to be highest risk for RSV complications. So the grandparents with diabetes, with high blood pressure, cardiac disease, COPD or emphysema, asthma, one of the biggest risk factors for RSV complications, smokers, cancers, obesity, among so many others. And this is what we saw this winter occur. So one of the biggest disconnect that we saw this season is educating the public on warning signs when to take the child or older adults with RSV to the emergency department. And I felt that some people waited too long, which is why, honestly, a lot of the cases ended up in mortality this year. One that I want to teach that I want you to learn so that you teach parents and you teach older adults, or you think about it next RSV season as well too. Any dry cough that's getting worse, you have to think of intercostal retractions or having a hard time breathing. This is a time to go to the emergency department. Unable to speak in full sentences because they're so short of breath. Any turning blue or oximeter readers less than 92% on room air are going to be signs to take this child or older adult to the emergency room. Signs of dehydration is the other big thing that I taught my patients about, because signs of dehydration is one of the biggest complications of RSV that puts kids and older adults in hospitals. So decreased urine output, or that baby whose actual diapers really go down or they're not taking liquids. These are signs to take them to the emergency room. And a fever that just is not responding to Tylenol or Motrin. These are the patients you take to the emergency department. So let's take a look at the statistics of RSV and children in the United States. So each year in the US, estimated 2.1 million kids go to an outpatient visit because of RSV. So that's a huge number. And each year in the United States, an estimated 58,000 kids are hospitalized with RSV. And when we looked in the statistics as well too, 1 to 2 out of every 100 children younger than 6 months of age are hospitalized with RSV. When we look at the death rate, which is so sad, 500 children die from RSV every RSV season. Now let's look at older adults as well too when it comes to RSV. So each year in the United States, an estimated 177,000 adults are hospitalized due to RSV infection. 14,000 adults die from RSV as well each year. And this is from data from the CDC. And most adults who die from RSV are greater than 65 years of age, which is a pretty young age when you think about it. So we want to make sure to also protect our older adults because these numbers really resonated with our Latino community this season. So I took this graph from the CDC when you were able to look at RSV data and look at it by actual race. So our Latino actual profile here for race is in green. So this is looking at the RSV season this specific year. What this graph tells us is that, one, we were the first actual population to get hit with RSV, and we were also the population to get hardest with RSV. So that's what this season is teaching us. It's teaching us that, one, there's predilection factors, major risk factors in our Latino community that made us, one, the hardest hit, and two, the biggest hit as well too, which we'll talk about in a few minutes. So in the next graph, what you'll actually see is also looking at the full RSV season over the last 3 years. And what you'll see is we fall median when it comes to we're the green line. And what that basically means that throughout RSV full season over the last 3 years, we've always been hard hit by this virus. And there's a lot of risk factors that go into why the Latino community is very hard hit. So risk factors, multi-generational homes, just like I mentioned before. So you have a lot of generations living under one roof. You have the grandparents, uncles and aunts, you have the kids, the parents, and everyone, which is part of our loving Latino community, but it also makes it very, very hard to isolate anyone who's sick. And it also makes spread of something like a virus like COVID-19 or RSV or flu very easily done. And that's basically what happens. We also have a higher prevalence of asthma as an underlying risk factor in Latino children, which is one of the big things that I want to highlight and teach any physician that's on this actual webinar today, because that is one of the big risk factors that we should look for complications from RSV. Then there's lack of education and identifying when to take a child or an adult to the emergency department. So there's that disconnect that we need to do because there's a language barrier. We need more materials in Spanish, reliable websites with Spanish material as well on RSV, national media on radio and TV, kind of giving this messaging as well too, which is going to be important as well too. And lack of medical access, we have to think is why the Latino community also got hard hit, because a lot of pediatrician offices and also adult offices, medical offices, one, were closed due to the pandemic. So a lot of them just took virtual if kids or adults were sick. And two, they needed a negative COVID test, a lot of them, to see these kids or adults who were sick. So a lot of them, didn't have the resources to maybe go get that test done, or the language as well too, or the technology to do a virtual actual visit. So those were barriers that we saw within our Latino community and them getting so hard hit by RSV. So, but there's hope. And I have to talk about the hope that there is. So there's RSV vaccine development coming. And one of the vaccines that's coming is by Pfizer for pregnant mommies. And so this vaccine has already been shown to be 83% effective to protect babies within the first 3 months of life, and 75% effective to be protective against RSV in the first 6 months of life, given third trimester of pregnancy to mommies. And we hope to have it available before the fall. Pfizer is also working on a vaccine for adults older than 65 years of age that will be a yearly RSV vaccine. It's up for FDA actual review in May, and we hope to again have it before the fall season. So that's going to be very important. And then we also have GSK in the running and Moderna, who's also trying to develop an RSV vaccine in adults. We also have monoclonal antibodies in the works that will help neutralize RSV in the babies and also in older adults. So lots coming. But what that means is, as the Latino doctors and those of us helping the Latino community, we're going to have a lot of work to do, because we're going to be on educational vaccine campaigns. We're going to have to talk on the media, everything else, because we're going to have to teach our patients all about these vaccines and how safe they are, so that our community is better protected. So how do we bridge the gap in health disparities in the Latino community when it comes to RSV? So again, protection and education are going to be key. Two, we need to discuss masks and importance of providing free, reliable online resources in their language as well, to keep children, older adults, and immunocompromised people really, really safe. And we have to encourage the Latino community to get the RSV vaccine once available. As the medical community, that means we have to be at the forefront, and we need to provide really a lot of reliable and trusted resources in Spanish, websites and hotlines in Spanish as well too. Vaccination campaign that I'm sure all of us here on this panel will be working really hard on, which means going on national media, TV, to encourage and educate the Latino community on the importance of the RSV vaccine once available. And then also providing RSV vaccines at medical facilities that are going to be accessible for our population as well too, and making them affordable even for the uninsured is going to be key in bridging this gap for our Latino community when it comes to RSV.
Thank you so much, Dr. Mora. Very, very robust presentation there. Looking forward to going over the Q&A and seeing how we can dive even deeper. So thank you so much. And I'll turn it over to Dr. Cabrera.
Thank you, Dr. Mora. Thank you, Dr. Garza, for those summaries. It's amazing to see these three illnesses kind of laid out side by side. I mean, the similarities in sort of the risks to our community and the call to action to kind of combat this disparate effect in our Latino community, they're the same. They're the same. And so I'm sure it's no understanding flu and the impact in the Latino community and RSV and the impact in the Latino community probably should be no surprise to us how COVID hit us so hard, you know. I want to, today in the time I have to talk, I want to share some of the pearls that I've recently learned from a COCA call. Vito, if you can show the next slide. There's the CDC has this clinician outreach and communication activity, COCA, and they had a recent one on COVID. It was January 24th. So some of the statistics that I'll share are from that call, and the latest we have to get. Access is available on this link. Next slide. This is an epigraph of COVID cases in the United States since the beginning of the pandemic. Over 100 million cases in the US so far. About 25% of those are estimated to have been in Latino or Hispanic people. And yet we only make up about 18% of the population. So for sure, a number of cases. And this data is understandably imperfect. You know, at the beginning, you don't see that many cases, but as you'll see in other slides, the deaths were tremendously high. Access to testing was a problem in the beginning and may undercount those cases. Later on, and now in these latter stages, in these last two waves that you see, the highest peak was Omicron in January of last year. The two subsequent surges that you see were caused by the Omicron variants, BA.4, BA.5, that first smaller one, and then the most recent one, the newer variants, that surge started right after Thanksgiving. Now we think, you know, the number of cases probably are mitigated because of greater immunity from vaccines and from natural immunity, but they're also maybe undercounted because so many people, there's greater access to testing now, and people might be testing at home and not seeking treatment or reporting it. Next slide, Vito. This and the following one may give us a bigger picture of the impact in health. This is data published by the CDC on new admissions of patients diagnosed with COVID. Gosh, we can see that peak also in January due to Omicron, where hospital admissions were occurring at greater than 20,000 per day on a 7-day average. With this most recent surge, we could see that they peaked at about 6,000 admits per day on an average over the last 7 days. And that recently it's begun to climb down a little bit. 4,800 was the last data that was published. Now, same mitigating factors, maybe less people being admitted to the hospital, maybe less severe disease because of natural immunity, vaccines, or access to therapeutics, which we'll talk about. And maybe some reassuring inferences that we can gather that maybe these latest variants, although very contagious, aren't necessarily more virulent. Let's look at deaths next. Vito, next slide. So over 1 million or 1.1 million deaths since the start of this. It breaks your heart, And estimated, you know, the estimates to try to estimate the deaths in the Latino community can vary. You know, if you just take a look at the reported deaths, I've seen the CDC report maybe as low as 15.4%. That's about 180,000 of these reported deaths. But, they know they're being undercounted for various reasons, and they have these epidemiological techniques where they use weighted population distributions to try to get a bigger sense of how many deaths were within our community. And that number goes up as high as 33% if you apply these statistic adjustments. And so that's close to 400,000 of these deaths. So it's a lot of deaths. Currently, the 7-day average is about 600. I think it peaked at 600. And then with this last report on January 18th, it was beginning to decrease to a little below 600. That's 600 deaths per day in the country. Still, many preventable and unnecessary. Not all of them, but many are. Next slide, Vito. I wanted to share this slide. It really shows the distribution of the variants that are affecting our communities and how rapidly it's changed. If you look at the dates on the scale, it really goes from October, last Halloween, to now, and how rapidly it changed from predominant BA.5 to these new variants, XBB, and then the BQs, BQ.1, BQ.1.1 have become the majority. And XBB is rapidly becoming a greater player. Right now, according to these latest statistics, it was about half of the cases, but we know in certain regions of the country, in New England, New York, it's greater than 80%. What's the significance of these? These are mutations. This is an evolution of the virus, and they survive. They have a competitive advantage, and that's why they displace the other variants. So that's why they watch them. They do that surveillance. What we know so far, implications that we do know so far, is seem to be more contagious. The mutations that have occurred in these variants of concern right now are on the superficial proteins, like the spike protein. You'll hear about that. So it makes it a little bit more difficult for the immune system to initially detect them. And it's resulted in monoclonal antibodies, like the last one that we had been using was bebtelovimab, and Evusheld, therapeutics that target those surface protein. It's made them ineffective. Now, what's the good news? The good news is these mutations don't necessarily seem to be more virulent or cause more severe disease than the others, and vaccines and the antivirals seem to be effective. Next slide, please. Okay. So this is, a graphic representation of the vaccine program in the U.S. by ages, and the three graphs are divided at least one dose, those people that have completed the primary series, and then the bivalent booster. Big difference is evident to all of us just from looking at this graph. We know that people at higher risk are elderly members of the community, had high vaccination rates. And then that vaccination rate seemed to diminish with age. Unfortunately, the uptake for the bivalent booster dose has been less than adequate. And you can see, even in our most vulnerable, because most of the deaths are occurring right now with COVID in people above 65, that population is still only 40% vaccinated with a bivalent booster. What information do we have about our Latino community? Next slide, please, Vito. Okay, so this is data that's published on CDC's Vaccine Equity website, and it clearly shows that while we've done well, and I think we started slowly, but efforts like Vaccine for All, efforts in education, efforts from trusted Latino physicians to have really increased the numbers. If you look at least one dose and completed primary series, we're very good, in the high 80s, comparable to those in the white non-Hispanic population. But if you look at uptake of the bivalent booster, we're very, very low, 12.7%. Compare that to 30% in the white non-Hispanic population. So we've got work to do. We've got work to do. Next slide, please, Vito. Okay, this slide shows the life cycle of the SARS-CoV-2 virus and where are available therapeutics really directed their efforts. As I mentioned earlier, the monoclonal antibodies and Evusheld really focused on superficial proteins, and those unfortunately are more amenable to mutations, and that's what we saw happen. That's why they're no longer ineffective. The other two targets of the antivirals we do have are more targeted at internal proteins. The protease inhibitor Paxlovid, and then molnupiravir and remdesivir. They both act on RNA replication, inhibiting RNA replication. So internal proteins, less likely to mutate, or at least thus far, and so they are effective. Next slide, please. Now, part of the problem, and I know this actually from health policy research that I'm doing as part of my fellowship with the NHMA. We've researched healthcare inequalities in the rollout of Test to Treat program. And there have been recent studies by the CDC that show that our Latino community is underutilizing therapeutics. And so, and that's for a combination of factors, probably same factors why we have lower vaccination rates, probably same factors why we have lower flu vaccination rates. And we can all do our part to try to remedy this. So part of it is educating and increasing the comfort level of our physicians and nurse practitioners and providers that are taking care of the Latino community. And, you know, that's why I want to challenge the NHMA to do their part in educating and increasing the comfort level of prescribing these therapeutics, especially for our high-risk patients. This chart also taken from that Coca-Cola I wanted to share because it lays out the three antivirals side by side, makes it a little bit easier to understand their differences. Paxlovid and remdesivir clearly have greater efficacy. So think of those first. You know, as high as 88% risk reduction on the initial studies that were used to approve it. And they have been followed up by real life studies, sort of prospective or retrospective observational studies in a more diverse population. Those that have been vaccinated have some natural immunity, and they still had a significant benefit, especially in those with risk factors greater than 65 in there. So they're highly efficacious. Paxlovid is an oral regimen. It's currently funded by the government, so cost shouldn't be an issue. It's safe to use in pregnancy. The problem and the limitations are with their significant drug-drug interactions. Educating our providers and our colleagues about tools that are available by the NIH has a great tool, and the University of Liverpool has another tool which I've used often in the urgent care to track drug-drug interactions. Remdesivir, again, highly efficacious, studied in pregnancy, fewer no drug interactions. The limitation is logistical because it requires an IV infusion for 3 consecutive days. Our patients that we send to the hospital end up getting remdesivir. But it's difficult to logistically to accomplish that, not impossible, but difficult on an outpatient basis. And then molnupiravir, that's that third oral antiviral, no drug-drug interactions, but less efficacy. 30% risk reduction compared to those of 80. And so save it as your second line. Not everyone is going to be able to take Paxlovid. Not everyone is going to be able to get remdesivir. And so that's where you use your molnupiravir, okay? Don't have to worry about drug-drug interactions. Not contraindicated in pregnancy, though. Need a creatinine clearance greater than 30, but there's no renal adjustment. Paxlovid and molnupiravir have to be used within 5 days of symptom onset. Remdesivir has proven efficacy a little bit longer, within 7 days. It will have benefits. So this is a window of opportunity, increasing utilization, increasing knowledge of those antivirals, especially among our highest risk members of our community. Next slide, please, Vito. So I've added this this graph, and it really breaks down sort of the thought process as you analyze a COVID positive patient. Should I treat them with antiviral therapy? Those patients that are at higher risk for complications, severe illness, hospitalization, and death have the greatest benefit. Makes sense, right? And those subsequent observational studies that I've showed have confirmed anyone greater than 65 absolutely will benefit, whether they're vaccinated or not. Anyone unvaccinated, regardless of their age or other comorbidities, would clearly benefit from antiviral therapy. Those in between, those vaccinated, but maybe less than 65 or less than 50, it's more nuanced. And so the clinician needs to analyze the risks and the benefits. And this graph is a useful tool that I've used with our providers in our urgent care to help them be more comfortable at prescribing those antivirals and helping keep people out of the hospital. You know, it's kind of divided into 4 subgroups. Age, of course, the older you are, the higher risk you are, the younger, the lower the risk. Medical conditions, amazingly, the same risk factors for flu that Dr. Garza mentioned, the same risk factors, particularly for our elderly RSV infected patients that Dr. Mora mentioned. Diabetes, chronic kidney disease, hypertension, obesity, lung diseases, cardiac disease, and pregnancy. And the presenter on that COCA call from the CDC did mention, and this was something new to me, that there is a cumulative. The more of these risk factors that you have, the greater your risk is. That's why this slide is scaled in that way. Vaccination status. Unvaccinated, clearly think of antivirals. Fully vaccinated and boosting, lower risk. Unfortunately, we know from the utilization of the COVID booster, most of our patients fall in between as partially vaccinated or fully vaccinated, but not boosted. And so it's nuanced. You have to think, you have to analyze, you have to do what's best for the patient, balancing those risks and benefits. And then the third category that you really need to think of is those rare patients you may encounter that really have some sort of immunosuppressed illness. Those absolutely should be offered antivirals if they're positive, regardless of vaccination status. Next slide, please, Vito. All right, so what's the call to action now that we're all fired up about helping to protect our community? Same message. If you protect yourself, you protect your family, your abuelitos. If you protect your family, you can protect, if you protect yourself, you can protect your classmates, you can protect your colleagues at work. If you protect yourself, you can protect your community. And so shared responsibility, we're all in this together. And yes, as much as we'd like to forget, we're still in this together. Number one thing you can do, get vaccinated, get boosted. It can make a huge difference, especially if you're at high risk. Number two, get tested if you have symptoms. Don't wait. The therapeutics and seek treatment. Go to your doctor and seek treatment if you're positive, because we have treatments that are available that are effective, especially if you're at high risk. Wear a mask where recommended. Stay home if you're sick or test positive to isolate and to prevent others from getting sick. We all have a role to play. Okay, thanks, Vito. Back to you. That concludes my part.
Thank you so much, Dr. Cabrera. Thank you for providing us that overview and your contact information there. This will begin our Q&A portion. So I know that was a lot of information to digest across the board. So for the audience, I'll give you another minute or two if you would like to put a question into the Q&A box, and we will address them. We do have some time, so please feel free to ask a question if you are interested, and I'll stop sharing my screen for us to have a little conversation here. All right, so we do have some questions coming in. Now, I will filter them and try to pick the best panelists to answer, but for the most part, if it will be something that everyone can answer, please feel free to jump in. We can have this kind of be more of a conversation. So the first one that we have is, with RSV, the flu, and COVID-19, how far are we really from the end of state of emergency? And I will allow all of you to answer that if you have an answer for it.
Well, according to the Biden administration, May 11th, but most pandemics last 5 years in all reality. So most pandemics, we are, obviously going into year 4. So we're currently in the 3rd year. And so I think it's going to last a little bit longer, which means we still have to continue to keep our guard up, just like you heard from Dr. Cabrera and Dr. Garza and myself. And I think it's going to be important that we continue advocating for vaccinations in our communities, that we advocate for taking care of all generations and the immunocompromised, because all these viruses mutate fast. And if there's lessons that we have learned in this pandemic, is we need to stay on top of this virus, because COVID-19 has no mercy. And when it comes to mutations, RSV was so hard hit in our community, and so is flu.
Thank you, Dr. Mora. I will allow Dr. Garza anything to add. If not, no worries.
Nothing to add. I think she hit it on the head.
All right. And Dr. Cabrera?
I would add that one of the concerns with the end of the state of emergency that's being proposed in May, it's going to pose additional challenges with regards to cost of these therapeutics. They're not cheap. Cost of the vaccines, how much is it going to cost for a cash paying patient, to get the vaccine? Mm-hmm. And so I think there's going to be some challenges ahead that we need to try to anticipate and plan for, how to get access to those vaccines and therapeutics for patients that may lose Medicaid, for example, and if that funding is not there for the cost.
Absolutely. Very good points all around. Thank you. So for those of the attendees asking, we will be sharing the recording and the slides after through email. We'll also have them on our website, and we'll be able to link that for you. Let's see. We have another one, and this asks, in Southern Idaho, we have noticed a barrier to the Latino community in getting vaccinated with us, and that us meaning the local health department. It's a worry that if they get vaccinated for flu or COVID, they will be reported for not being a documented citizen or immigrant and lead to deportation. How do you recommend we combat this barrier?
Well, I think one of the things that we've done here in Chicago is to really kind of build that trust factor. So that's what's needed, right? Making them feel safe. So I can tell you as a private practice allergist, what I did is if someone was undocumented, I told them they would go into the system, but I didn't take down their address or their phone number so they could feel safer. So that was kind of a way where I built a trust within them and was able to give them the vaccine. Two, through the American Lung Association, we also built a website within the page at lung.org where we put resources in Spanish and English. And we put videos out on starting the conversation, why it's so important to bring these actual myths or barriers of misinformation down. Your documentation status in the US is not at risk. No one is going to report you. This is to keep you safe, etc., so that people build that trust. But I think one of the big things that I would suggest for Idaho is getting them into doctors' offices that they trust already. Because that way, if they trust the doctor, they're going to be also trusting them to give them the vaccine. So I think more access within their neighborhoods, going to the supermarkets we did here, to the barber shops, things like that. We even walked around churches. Churches are big actual opportunities. So that way you bring in the vaccines to the local communities and get them vaccinated.
Absolutely. One of the lessons that we learned is that practicing clinicians and local health departments need to build stronger relationships and communications. The need is there for fighting all of these illnesses and those that are going to be coming in the future. And so, the local health department should reach out to those local doctors that are taking care of that community. Tap into the NHMA, see who the members are, find out who they go to. Trusted people. Yeah.
I completely agree with not forgetting that churches are a place that Latinos like to go to, and they will trust their parishioners, and they will trust their priests and all those folks, and it's a safe zone. And getting back to the question of some people who don't have an internet, on the next question, not everybody has the internet. Not everybody goes to other facilities, but a lot of them go to church.
Yeah, absolutely. Dr. Garza, thank you for that segue. I do like that question a lot, because it's something that we get asked also here at NHMA. And I will address this from Claire Paprocki. Thank you for the question. So it says, lack of education and trust is a recurring theme with the Latinx community. What are the panelists' recommendations on reaching this community? Social media, marketing, TV, etc. And then what about those who don't have access to the internet? So great suggestions there. But if anyone wanted to kind of build on that, I know we do things like that with our Vaccinate for All campaign, but if anyone had deeper insights there or experiences.
All of the above. Radio, TV, local health fairs, free vaccines, campaigns to screen for sugar. All of those activities need to be in there. Networking with the providers, the pediatricians in the community. Those that are Latino and not, but those that are serving the community, just networking with them, making sure, that message is constant. Church for sure, that's always an opportunity.
I think media is going to be super important. Definitely. I agree with all the points made. And I think obviously getting doctors who are trusted to go on the media and talk about the vaccines and how they're developed. And so, for example, I have a weekly segment that I've run now. It's going to be 2.5 years almost on Univision Chicago. I come on every morning, Wednesdays, 6:15 a.m. I go live. And I make it like a little podcast. So I teach the community about, okay, what are we doing with the vaccines? What's the latest on, like tomorrow I'll be talking about the May 11th and what that means to our Latino community, which is why they should get vaccinated now, et cetera. But it's starting the conversation, but continuing it on. So that way it's really building that trust, but it's also that conversation that will prolong, which is nice.
Absolutely. Thank you. All right. So the next one, I have a few of kind of a similar question. I think Dr. Cabrera, we could probably start with you, but everyone, of course, feel free. What is the best way to increase awareness and getting treatment for COVID for our Latino communities? And then we had another one asking, where can we get more information on Paxlovid?
Mm-hmm. Absolutely. You can get information on the FDA website, the CDC website, and also you can also find the Test to Treat program. ASPR operates that website, and they've got a tool there that'll help you locate where to get the medicines. So the sites, the pharmacies, the community health centers that have been given that medicine, and you have access to it. We've noticed a big difference between the rollout of the vaccine and the resources that were dedicated to the rollout of vaccine education, commercials in Spanish, translation of informational material, toolkits for physicians in Spanish for the vaccine. The funding was there. When the Test to Treat program was rolled out by ASPR, they did not have that funding. And we saw the limitations of that lack of funding. Those resources, the same resources weren't there. And that made it a challenge. And that's probably why such a large segment of our community weren't aware these therapeutics were there. Those commercials weren't rolling on their TV, on their radio. A lot of those tools now are translated by ASPR and available, so there's information we can give out to our patients to educate them about that. And then all the grassroots efforts that we've talked about earlier, we can do that specifically for Paxlovid and the therapeutics. But first, we have to become comfortable in understanding it and prescribing it. So, part of it is educating ourselves.
Excellent. Excellent. Thank you. All right. So I want to go back a little bit. I got a question that kind of reminded me of when we were first kind of rolling out the vaccines and then kind of hearing about COVID all the time. So Dr. Diana Torres Burgos, thank you for the question. And she asked, how do we address vaccine fatigue? It's the most common response I get when asked why they're not getting the booster dose, especially seniors. And this can also go in a little bit, Dr. Mora, with, or actually for all of you, about FDA's proposed annual COVID vaccine, because it's going to be booster after booster after booster, and that annual might really switch things up a little bit. So I guess we'll go back to how would you all address vaccine fatigue?
I would tell them, and this is what I tell my patients, because a lot of them come in here and go like, Dr. Mora, I'm tired. But you start the conversation with them, every single family member, every single family that hits my office, I always start with getting the status of everyone's COVID-19 vaccinations because I have them here in the office. And then they're like, didn't we just take one? I'm like, no, we checked the system. It was over 7 months ago. You need one. And they're like, do we really need one, Dr. Morrow? It feels like we just took one. And we've been so fine, everything else. And what I tell them is, look, would you give up near the end line of the marathon? So no, you wouldn't. I said, you want to continue fighting the fight, which means keeping up to date with vaccinations. We want you to stay well. We want the rest of the family to stay well. So let's get that vaccination in. And they usually leave with the vaccination.
I love that, Dr. Mora. Anything else to add, Dr. Garza, on that?
No, I agree. It just takes constant reminding.
Absolutely. And Dr. Cabrera, anything?
Oh, you could, but it makes sense, right? If we have one vaccine a year, it would be much easier to accept than 3 or or even 2. So it makes sense if we're able to accomplish that. It's also less expensive, hopefully, to just get one vaccine rather than 2 or 3 throughout the year, especially as cost becomes more of an issue with the end of the emergency.
Excellent. Thank you. I have just a few more questions here. Dr. Garza, I wanted to ask, so in the past 3 years that I've been with NHMA, and unfortunately I joined here right as COVID happened. So we've been, looking at all these barriers and doing these webinars and Twitter chats and a bunch of other things. We typically see like the common barriers that we all address in getting vaccinated. How do we finally address these resurfacing barriers for the Latino community? How do we finally, when can we hold that webinar where the barriers aren't almost the same that we mentioned in previous years? Tough question, I'm sorry, but.
It is, and a lot of it is perception. We have the economics, we have the demographics, and I don't have a physician, I don't have insurance. Yes, but I think that you have to start with why. If you let people know why it's so important, not just that they have to do it, but why they have to do it, then I think you're gonna be more successful. I think if you also use
I think you froze a little bit there, Dr. Garza. Let me see if I can stop it. If you turn your camera off, it might not freeze. But in the case that Dr. Garza is frozen, let me know if you're back, Dr. Garza. I did have one more question. I think it's a really good question for the whole panel. There you go, Dr. Garza.
Sorry about that. Yeah, my instability is my reputation. I think they've used local heroes, people that are respected. You might reach a broader audience, people respect people who look like them, talk like them, live like them. So I think if you can get people from the churches, from the schools, from the universities, from their organizations to get up and make the pitch. And so it's not just physicians from on high making the pitch. They're more likely to understand it and to buy it. The peer network is also very, very important. So, we need to multiply our efforts by
think you went out a little bit again at the end there, but totally understand where you're coming from. I think from where we've been, we made a lot of progress. So definitely don't want to undermine any of that, especially with experts like yourselves. I think we have come a long way. And then I'll sum it up with this last question for everyone. Question from Jalissa Soto. Thank you for your question. So Jalissa mentioned that sometimes clinic hours and our community, working all of, multiple jobs sometimes, and not always being able to get out of work. What does our community do if the clinic hours don't always line up with their hours to get vaccinated or see a doctor?
That's why I have a job, because of the urgent cares. Now, obviously, urgent cares tend to be clustered in urban centers. They aren't always where you really need them the most, in rural areas, in certain communities. One part of the emergency that it expanded the use of telemedicine and access through televisits to maybe some care at different times. Now, I'm not sure how if it's ever going to go away now that it's here, but it's going to adapt. But there will be challenges in reimbursement. Now, it is a big challenge. Access in general is a challenge, regardless of the hour of the day, for many people in our community, but especially those that work from daylight to sundown. Where do you go after? Okay, those are two options. Saturday clinics, some primary cares and community clinics are primary care. And then really the success and the growth of the urgent cares has kind of forced primary care clinics in pediatrics to evolve and to provide a little bit greater access. I think pediatricians have always done a little bit greater job of that, but now I see community health centers also having sick days, 6 visits, Saturdays, extended hour clinics. And so that's all good. We're talking about increasing access for our patients.
Absolutely. Thank you, Dr. Cabrera. And I also saw in the Q&A, Omira Gaiacello. She mentioned in Illinois, there are areas where they can send providers to people's homes to vaccinate them as well, which again goes back to kind of what we were talking about before, is like meeting our community where they are. And I think that that's a great thing. So we are coming down to the final few minutes here. So I'm just going to address some questions that were a little more NHMA related real quick, and then I'll bring up the final 2 slides. So is NHMA offering this information to physicians in Spanish to make it easier for them to share with their patients? Thank you for the question. We absolutely are. We have an entire resource hub covering a wide array of illnesses, diseases, called HispanicHealth.info. We have a whole side for patients and a whole side for providers. The entire resource hub is bilingual. So we are, always thinking of that. We do also print out materials front and back, Spanish and English. So we do have those. If anyone is ever interested, please reach out to us. We can do our best to help you out, make sure that you have those for your community. And we will have this topic in our conference in April. We'll be covering, again, a wide variety of some hot topics at our conference. And I'll share my screen with more information on that. So our 26th annual conference is coming up in Chicago, Illinois. We're very excited to take the conference out of DC, switching it up a little bit. Excited to get out to Chicago, April 27th to April 30th, 2023 at the Hyatt Regency. Again, our Vaccinate for All campaign, there's the website there, the HispanicHealth.info. We also have another microsite for our campaign, vaccinateforall.org. We have a huge cohort of individuals and organizations that sign up for free to participate in these webinars, to host vaccination clinics, vaccination education events. Scan that QR code. It takes about 60 seconds to sign up. It doesn't cost any money. We're really looking forward to just creating this cohort of trusted messengers and organizations that we can work together with to help increase the uptake of flu and COVID-19 vaccination in our adult Latino communities. The bottom QR code, we have a bunch of events. As you all know, we're always running webinars, always running Twitter chats. There's always something going on here. You can scan that QR code. If you have any questions, please email us at nhma@nhmamd.org. And the final slide, please scan this QR code for our post-webinar survey. We will be raffling off a $25 Amazon gift card. The survey is anonymous, but if you do want to win the gift card, you can put in your email just so that we can contact you. Again, this does really, really mean a lot to us, so that we can continue to enhance these webinars. And of course, follow us on social media. We're very active on social media, so want to get connected with all of you, amazing physicians, healthcare workers, and other organizations out there, so that we can create new partnerships and continue to move health forward for the Latino community. And that is all that we have today. I wanted to say thank you again so much to all of our amazing panelists for your time, your expertise, and your insights. I know that I certainly learned a lot today, and I know that you're all very busy people, so we appreciate you being with us today. Thank you, everyone, for joining the call. It does mean a lot to be able to work with all of you, and we will be sending out the slides, the recording, and the links to our websites and resources in an email, probably in a week or so, along with the post-webinar survey for everyone to complete. So thank you all again. Thank you to the CDC and Health Monitor Network, and we will see you on the 20th session of our next virtual briefing. Thank you. Take care.
Thank you.